So we have Tom Dye now, who is a internationally respected pediatric neurologist who studies sleep disorders. And Tom, welcome, and thanks for joining us.
I'm going to speak about sleep and epilepsy, how it relates to DLG4 and SHINE, and we'll go through a few things. I don't have a lot of answers. A lot of things that I feel that people are interested in knowing about, but we're not quite there yet. So as we saw from the Searchlight presentation, epilepsy and sleep issues are really common in DLG4 SHINE. About half the kids seeing some form of that. So I'll start with the sleep concerns. And when we talk about sleep, that's like such a vague issue. Sleep takes up a lot of the day, a lot of the 24-hour cycle, and just saying, oh, sleep concern or sleep disorder. But what do we mean by that, and how are we going to evaluate it? Well, generally speaking, we're going to divide it up into three different avenues. We have the onset, meaning falling asleep, difficulties falling asleep or initiating sleep. We have the sleep maintenance issues, which we see quite frequently, and not just in DLG4, but in neurodevelopmental disorders in general, where you might be able to fall asleep, but then your sleep is disrupted, it's broken, you have trouble sleeping all the way through the night. So that's sleep maintenance issues. And then lastly, but not least, is the timing. And by timing, we mean the circadian aspects of sleep. So, our sleep-wake cycle, it operates on a 24-hour cycle, a little over that, but it has to be synced up to the rest of sleep. So if you're trying to, we can't just magically flip a switch and sleep during the middle of the day. All of that has to be regulated in a time that fits with what our internal battery wants to do, as well as our internal clock. And we see also, when you compound that, which we also saw from some of the Searchlight data, that when you combine that autism, ADHD, and anxiety with genetic disorders like DLG4, that those feed off of each other and make the sleep disorders, the sleep difficulties, more prevalent or more noticeable. So it's usually not just one thing, and it's not one thing that you can just fix one domain without addressing everything. Okay, so let's start with the maintenance and evaluation, how we would go about it. So if you think kind of the zoomed in version is going to be the PSG, the polysomnography. And usually we're doing this in usually every time we're doing this in a sleep lab if you're a child. It's really thorough. It gives us lots and lots of detailed information, what is going on during the night. And as long as we capture enough sleep, as long as the duration is long enough, we generally get a good sense of what sleep could be like, from a physiologic standpoint. But it doesn't tell us anything about the behavioral components of sleep or necessarily the timing of sleep. And by behavioral, I don't mean like a bad behavior, but just how our bodies interact with the environment and what is our default response to an environmental cue. The next step up would be actigraphy, and that's essentially just a high-tech motion tracker. And it has benefits in that it can tell us longer periods of time, but it doesn't tell us anything about the sleep physiology itself. It basically just says, is the child moving or are they not? And from that, using different algorithms, you can calculate whether or not they're asleep. But it doesn't tell us everything. And, it's some kids, particularly with sensory issues, aren't going to want to wear what is essentially a wristwatch for multiple weeks. And last but not least is the sleep diary, which is really important and overlooked, I think, a lot when we're trying to establish a pattern. What if you can't see the forest for the trees? As they say, if you take a step and let's just chart this out every night, you might be able to have a little bit more pattern recognition. Okay, so let's start with polysomnography of those. And actually, we'll stop there too. We won't get too much into the other aspects of sleep evaluation. But the polysomnography, when we're looking at kids that have neurodevelopmental disorders, kids with DLG4 shine, we're really talking about the EEG component. So this is just a screen grab of a polysomnography, and you can see how much information we gather from it. This top portion here is what we're looking at from the EEG standpoint, and that is what we'll talk about mostly in this talk. But we also get movements, what the respirations are doing, and also how the muscle effort is. And in kids with low muscle tone, the capnography, which is measuring end-tidal CO2, so gas exchange, is important, as is the effort that they're doing while they're breathing. Although we haven't seen a ton of sleep disordered breathing issues in DLG4, it's worth noting. So, but we'll focus on the EEG. So this is wakefulness. And just to point out a few things, we're not gonna have hopefully we won't have 20 or 40 different electrophysiologists trained by the end of this talk, but it's not that complicated to be completely honest. It looks like squiggles, and that's what they are. They're just electrical recordings of what the brain is doing. And it goes up and down. And the reason it goes up and down is because our neurons are depolarizing and repolarizing. And if you think of a battery that has a positive and a negative charge, that's all it's doing. Those neurons are sending the chemical signals, which we're picking up as electrical signals, back and forth. And if you put a bunch of them together, they create an electrical field, and that electrical field is what we're measuring. And the fewer that you have together, the smaller and the faster the field. So in this case, each one of these is a second, so it's going back and forth 10 times a second. Now, obviously I'm a sleep specialist, so when I'm focusing on EEGs, I'm biased in the sense that I think that this wakefulness is boring. It doesn't do anything. It just looks like this the whole day. Whereas when you start to transition to sleep, we see immediate electrophysiology changes that we don't pick up during wakefulness. Wakefulness, obviously you think about what our brain is doing when we're awake, and it seems more exciting. But from an electrical physiology standpoint, it's boring. We don't do much. But as soon as we start to transition to sleep, you see the changes. I mean, you can see how this starts to drop out. And as we transition into light sleep, we get this slow rolling eye movements, which when I give lectures a lot of times, people are going to go into non-REM 1, like during this talk. It's this slow rolling eye movement. You start to drop off, and your background drops out a little bit. This is not restorative sleep, but it's there to protect us. So if somebody will probably, if they nod off during this talk, you'll hear that like the smack as their leg kicks. Well, that's when we transition to non-REM 2. That's the reflex there. That's it's that falling reflex that we feel that keeps us safe, to make sure that we're actually trying to go to sleep. So non-REM 2 is real sleep, and you can see we're starting to get new signals that we weren't seeing. This is a sleep spindle. This is a K complex, but it already doesn't look like wakefulness. And then finally, as far as non-REM sleep, and this will become important when we talk about some of the epileptic encephalopathies in DLG4, but we get to slow wave sleep, which is the most important and the most restorative sleep. I had mentioned that the more neurons that are synced together, the slower and the higher amplitude. And so here we've slowed down to about 1/10 of the speed as we are when we're awake. And that's important because in slow wave sleep, those slow oscillations, instead of back and forth, back and forth, back and forth, the slow oscillations are what we're using to kind of bathe our brain in cerebral spinal fluid and clear out metabolic waste products and consolidate memories. Everyone talks about REM sleep as being the most important, but it's actually the slow wave sleep. REM is interesting, we dream, but it's really more like being awake than it is being asleep. And then just to highlight the differences there, we've got up top here, this is the slow wave sleep, and this is wakefulness. And if you looked at this, and I hadn't just walked you through that, and I said, do you think that you wouldn't even think this is the same person. You might think that they're different creatures, like maybe one's a mouse and one's a human or something. But no, this is the same person. And probably, when you're young, this is a child, you go from wakefulness to that deep sleep, that pull you, drag you by your heels up the stairs and hit your head on every step and they're totally out. That's slow wave sleep. That's the sleepwalking sleep. You go there very quickly, 5 or 10 minutes. And so it becomes important, like we'll touch on later with epilepsy and how when you have disruption of sleep, particularly the non-REM sleep, can lead to developmental concerns. And like I said, last one, not one of the more interesting parts of sleep, but not the most important is REM sleep. You can see those rapid eye movements. The blue is eyes and the black is what your brain is doing. But it looks a lot closer to wakefulness than it does to the other stages of sleep. There's not a lot of change. It's a little slower, but it's not doing much as far as it's pretty stable. And this is actually protective against seizures, against epilepsy, in the same sense that wakefulness is. What's not protective against epilepsy or developmental and epileptic encephalopathies is the non-REM sleep, and particularly the transition points of non-REM sleep. So to also show the corollary here, non-REM 2 has these interesting features, REM doesn't. And so it looks less like, the REM looks more like wakefulness than the non-REM 2. So what does that mean from how you're feeling the next day? Well, the main thing is this idea of continuity or discontinuity. So for just about, I'm sure there's some outliers, but just statistically speaking, if you look at people and you had them have 6 hours of very continuous sleep versus 8 hours of fragmented sleep, you're going to feel much better after 6 hours of continuous sleep than you would after just discontinuous, a longer period of discontinuous sleep. And, again, you're not going to be an electrophysiologist by the end of this, but you can look and, this top one has less continuity, where here you have the longer periods of the quiescence. So not as much activity and then a longer quiet period. And this is just a different version of that. But this presents us with a problem when we're looking at sleep studies, because when we see the continuity, you can see this with your eyeballs when you're scanning through the tracing, and you say, "Hey, my gut says this has good continuity, this doesn't." But it's really hard to capture that sometimes in a standard sleep study report. So these examples have come. The top one, the least continuous, came from a kid with anxiety. Lots of wakefulness trying to break in. Anxiety doesn't magically disappear when you're asleep. You have that wakefulness trying to break into your non-REM sleep, your restorative sleep, and you end up with clear discontinuity. And the other one was a kid that just had sleep apnea that was treated, and the kid with sleep apnea, if you look at their macro measurements from the sleep study, they're almost identical. But this kid felt so much worse the next day compared to the kid with sleep apnea that was treated. So it might be that we need better metrics for measuring this. And some of the research we're looking at is evaluating the EEG tracings themselves, not from a scored standpoint, but from things like what's the spindle density? Spindles are there to try to keep us asleep. They come out of our thalamus, you generate a sleep spindle instead of waking up. It's sort of your brain saying, hey, stay asleep, stay asleep, stay asleep. And it's, on both sides, it's an inverse bell curve. So if you have too few, that tells us there's something wrong with your brain's ability to maintain sleep. And if you have too many, it says, hey, there's something that's trying to break into your sleep and your brain's trying to compensate for that. So that's one of the things we're looking at in from an EEG monitoring standpoint in kids with DLG4 and other neurodevelopmental disorders. And likewise, looking at this this power spectral analysis in which we see this, delta was those slow waves that we saw, and we want more of those. And so if we have different time points of the night where we're seeing more delta, how is that going to relate to restorative sleep and protecting against epilepsy, but really improving developmental outcomes? Because when you have a kid with sleep disruption and they have that, most of the time they're not sleepy during the day. They just have impulsivity, trouble with focus, essentially ADHD symptoms as the result of the sleep disruption and the sleep discontinuity. Okay, so moving on to the circadian aspect. Now, when we think about how we're regulating sleep, we have this is kind of a tricky slide to get your head wrapped around, but it's this two-process model, one being your internal battery. So you wake up and your internal battery is charged, and as the day goes on, you start to get more pressure from that. Your battery is saying, hey, I haven't slept in a while. I need some sleep. And as that is pushing this way, and your alerting signal is, this is your internal clock, is saying, hey, you should be awake at these times a day. You have a fluctuation in your wake. So the higher that this is, the more likely you're to be awake. And the lower, the more likely you're to be asleep. So you start off and you're not really awake. You're kind of groggy. And then you hit your morning, you have your little afternoon circadian dip. But one of the things that we do as humans is that before we sleep, we have the second wind where we get more alert. Now, if you're a kid that has autism, ADHD, a lot of times this second wind it just keeps going up. You don't shut it off. And that's where we see a lot of the issues related to sleep onset problems. Now, beyond the onset issues, we can sometimes end up with this sleep, this homeostatic and circadian mismatch in which your internal clock is either telling you like, hey, you should stay up later, or a lot of times what we see is that the internal clock is telling them you should go to sleep earlier. So you get really kind of cranky and crabby in the afternoon, have trouble with that sleep-wake transition, and then you try to wake up at like 3 a.m. We see that a lot, that advanced sleep phase. There's some evidence that kids with DLG4 shine we're seeing more of that. And generally speaking, in autism, we see that as well. And it's probably due to a mismatch between how their brain is regulating that 24-hour cycle versus the internal battery, where you're saying, I was pointing at the sleep load, sorry, but it's just to point out that the alerting signal, the circadian aspect is shifted in comparison to that. And when that happens, it's just like really bad. You're not awake during the right times of the day. You're not asleep at the right times of the night. You just get grumpy kids, right? And trouble with from a developmental standpoint. And how does that relate to, a lot of times this comes up, we talk about melatonin and the timing of medicines. Well, our brain is using melatonin, and this arrow here represents the dim light melatonin onset. It's when our body starts to release melatonin. It's trying to keep us in tune with the sun. So not necessarily relevant to this talk, but when you give melatonin before your brain releases melatonin, it makes you want to go to sleep or fall asleep earlier over time. If you give it after, the next day after you've hit your body temperature minimum, it makes you want to stay up later the next night. But what is relevant can be this light. And so when we have light exposure, after our brain has started to release melatonin, it starts to shift our body later. And this is, we do things in this country like daylight saving, which makes no sense. We're just, hey, society, deal with this 1 hour time shift. Oh, and deal with it again later in the year. Good luck to you, you know. But when it's, you know, I live very far west in the Eastern time zone, and in the summer it's bright out at 9:30. You know, there's no way my kids are going to go to bed that early because it delays their sleep phase. Vice versa, when you wake up in the morning and at the end of your sleep phase, if you get bright light when you wake up, it tells you to advance, meaning go to sleep earlier as time goes on. But if we have very early school start times where kids are having to get up before they've had bright light, then, you know, they're not getting that circadian cue and they're not able to go to sleep the next go to sleep at a later time. So this is you know, a genetic, societal, it's a multifactorial issue. But how does that, you know, segueing to the epilepsy part, which, you know, the sleep and the epilepsy are really, really tightly in tune. And the reason for that, well, before we talk about that, just wanted to highlight, you know, Zainab in her talk had mentioned this kind of this ESES and how there's a lot that it's a lot of classification and different people use different terms. And this International League Against Epilepsy, which is an amazing name, by the way, you know, an International League Against Epilepsy. You know, people don't come up with names like that. This is over 100 years, but it's like, wow, these guys were they were forming a league. That's like superheroes. But they're one of the things they're really focused on is the semantics of how we talk about epilepsy. And the most recent description, when I was training, there was basically just three things. You could either have epilepsy from a genetic condition, you could have it from a lesion in your brain, or you could have it from, we looked, but we couldn't find it. Those are the three classifications. And then beyond that, it could be either focal or generalized. But looking at most of the, you know, when we're thinking about the developmental and epileptic encephalopathy, that is what we're really evaluating kids with DL. That's the main reason for the epilepsy evaluation in kids with DLG4 from the developmental standpoint. And I'm not speaking specifically about individual seizures where we're saying, okay, this seizure puts you at risk. We don't want seizures to go on too long. We were going to treat epilepsy so you don't have seizures. That's one thing. You know, that's where you could have a focal seizure or a generalized seizure. They can be disruptive to the day. They can cause post-ictal sleepiness, so you can't function as well at school and things. But those are individual paroxysmal events. They have a start and a stop. You know, they're not there the entire time. When we think about developmental, the DEE, we're thinking more, okay, this is a developmental issue that is probably coming from an underlying genetic condition or idiopathic autism or something like that, which is also probably genetic, just not found. And it is likely having contributions from the epilepsy itself, leading to contributing or exacerbating the developmental concerns. And that's one of the reasons why we want to do more thorough evaluations in kids with DLG4. And so to put this this is from that paper I had mentioned earlier about putting the semantics of how we decide about what is the different naming semantics for epilepsy. And it's this kind of continuous picture, which is really one of the things that is interesting and so difficult with DLG4 and how epileptiform discharges during sleep can affect the development. Because we see plenty of types of epilepsies that have that have very frequent discharges during sleep, but have no development or limited developmental consequences. And, you know, the classic one is what they used to call Rolandic epilepsy or benign Rolandic epilepsy. It's not really benign, but that's just the term we use. And now it's called SELECTS. And those kids can have very, very frequent epileptiform discharges during sleep, but not a developmental or a very limited developmental issues. But then when we get into more of the activation meaning the spikes become, the epileptiform discharges, the EEG abnormalities become more prevalent, and a lot of times higher amplitude during sleep, and particularly the non-REM sleep, that restorative form of sleep, then we can lead to the encephalopathy. And when we talk about epileptic encephalopathy, if there was not a developmental concern before the epilepsy and having the development of epilepsy, that's the epileptic encephalopathy. If there was, then we will term it the developmental epileptic, meaning there was developmental concerns before there were signs of epilepsy. And some more fascinating acronyms that we'll try to not focus on too much, but and this somewhat depends on where you trained, but this idea of the epileptic electrical status epilepticus in sleep, meaning it's an electrical status epilepticus. They're not seizing, but you see so many discharges. That's the ESES. It's also in the past been called CSWS, continuous spike waves during sleep. And now the more recent is the spike wave activation in sleep. And then when you put that together, so if we think, CSWS used to also be kind of a clinical thing, but if you put together this finding with a developmental or an epileptic encephalopathy, then you end up with this encephalopathy with that. So you have to have both. You have to have the finding on the EEG and the developmental concern. And then if you don't have any of those, you end up with that. And you end up with epileptic encephalopathy without the slow wave activation, the spike wave activation in sleep. And to show you similarly what that would look like is that, and this is just like the most classic that you can see, where it's very normal during wakefulness, which is not always the case, and particularly if there are daytime seizures or seizures at other generalized tonic-clonic seizures or focal seizures, most of the time you're going to see some abnormality during wakefulness. But the point being that it becomes much more prevalent during sleep. And when you have this much electrical activation in sleep, what does that do? What does that do to the restorative and the developmental importance of sleep? And that's one of the things we're really trying to understand. How, if we treat this, how does it improve not just the epilepsy, but the development? And if it does, if we are able to improve the sleep continuity, irrespective of the spike waves, if you still have the spike waves, but your sleep continuity is improved, how does that help with the seizures? Because we know sleep deprivation is a big trigger. And how does that help with the developmental outcomes? And then just going back to that, I just put this in here to highlight that, the same way that we can see this fragmentation in sleep associated with the spikes, we see it with anxiety too. So we're looking to improve the outcomes by improving the nocturnal sleep. And to reinforce that the wakefulness and the REM are the same, and that's why, or not the same, but they're a lot more similar in appearance than wakefulness is to this slow wave activity, which is why we're so focused on this idea of counting how many spikes they have, which is super tedious, but it's the only way we know how to do it during non-REM sleep. Okay, and then just to point out that also when we think about these, there are certain syndromes that we know more about as they relate to genetics and epilepsy. And maybe one day DLG4 will be in this. We're not there yet, but hopefully at some point. So, it's hard to every kid, what do they say? Like, you've seen one kid with autism, if you've seen one kid with DLG4, you've seen one kid, right? So understanding and giving concrete recommendations is really difficult. But we talked about, because of the high prevalence of the epilepsy and the high prevalence of the epileptic encephalopathy and ESES, that at least a baseline routine EEG, and with a routine EEG doesn't mean that you don't have any sleep. It means that it's shorter, but ideally you would capture some sleep on it, so you could see that there's if you have activation during sleep, and then to consider a 24-hour EEG, an overnight EEG, to evaluate, especially in settings of developmental regression or routine abnormal routine EEG. And then from the sleep standpoint, this is the hardest one because you really just need, if there's sleep concerns, because they could be from so many different issues, circadian, onset, maintenance, behavioral. There's so many aspects that contribute to sleep and sleep disruption that really seeing a sleep specialist, pediatric sleep specialist ideally would be the recommendations. All right, so I think that's the last slide I had. But again, sorry I couldn't join you all in person. Hopefully for the next DLG4 meeting I will. But I do appreciate the invitation to talk, and we'll have other people from Cincinnati, I believe, speaking tomorrow about some of the other things we're working on.
Tom, thanks so much. So